Hello, everyone. Dr. PK from Dr. PK Live. And today I want to discuss a real case of mine. And this will be about hyperlipidemia and the need for coronary calcium scan. So, 63-year-old female with history of hypertension, hyperlipidemia, overweight, BMI of 29, lipoprotein 200, lipoprotein A 200, which is markedly elevated. Apolipoprotein B 99, borderline high, optimal for higher risk patient is generally um, less than 80 milligram deciliter. So in this case, why CAC is appropriate? 2018 and 19, American cardiology and AHA cholesterol guidelines recommend CSE scoring in adults 40 to 75 years old with borderline or intermediate ASCVD risk when the decision about statin therapy or statin intensity or additional lipid lowering therapy is uncertain. Now, this patient has several risk enhancing factors. Age is more than 60, hypertension, hyperlipidemia, elevated ApoB, very high lipoprotein A of 200, and she's overweight. And elevated lipoprotein A is particularly important because it is an independent genetic risk factor for premature coronary artery disease, aortic stenosis, and ischemic stroke. So the question is that how CSE would change the management. And in fact, I wanted to go over her lipid panel report. So her lipid panel, total cholesterol is 235, HDLC is 83, systolic blood pressure is 131. She's on blood pressure medication, valsartan. She has no diabetes, non-smoking. Her 10-year ASCVD risk is about 5 to 7%. So, and this lady is not willing to start a statin. She said, well, I need to know my risk here. So I applied for authorization for coronary calcium scan, and her insurance company is giving me a hard time. So how CSC would change the management in this case? Suppose her CSC score is 0. So she has very low short-term risk. Short-term risk. So, and she's, 60 is young, 60 is not that old. So she can still be living for another 30 years. Very low short-term risk. Um, so management would be, if she agrees, um, she can definitely take some statin and optimize her lifestyle and repeat CSE in 5 years if appropriate, right? And at least statin would help to lower her LDL from 135 further down. It's not going to make any difference in her apoprotein and lipoprotein A. What if her CSE score is 1 to 99? And that means there is definitely a plaque there, and she would be a candidate for moderate to high intensity statin and LDL goal of less than 70 if possible. If CSE score is 100, which is more than 75th percentile, she would be high risk. Again, high intensity statin and ezetimibe plus aggressive blood pressure control, um, and maybe a small dose of aspirin if the benefit outweighs the bleeding risk. And if her CSE score is 300 to 400, um, she'd be at very high risk, and should be treated just like somebody with a secondary prevention. And it's hard for a doctor when patient um, have such a strong opinion about a statin, and they're doing their best in terms of lifestyle and not able to bring it down, their cholesterol profile. I mean, this patient, I would love to have a target LDLC of 70, um, but it can go down to less than 55 if her CSC is markedly elevated, and aim for ApoB to less than 65 or 80, and optimize our blood pressure less than 130 over 80. And I have talked to her about um, encourage her to go for Mediterranean style diet and increase her walking distance and start lifting some weight. She's open to starting ezetimibe. So that's one option. Um, and I have talked to her about PCSK9 inhibitor, um, but she says she's going to consider that after she has a coronary scan done. But if her LDL remains elevated despite ezetimibe, of course, she doesn't want to take a statin. And if her CSC is high, PCSK9 inhibitor would be a right choice because that can help reduce both LDLC and lipoprotein A. And so she would qualify for non-contrast coronary artery calcium scan, and she would be an excellent candidate for CSC testing because result is likely to help refine risk assessment and help determine how aggressively I want to pursue LDL lowering therapy. Um, so 10-year ASCVD risk factor on her is about 5 to 7%, right? But this risk stratification of ASCVD, um, the important caveat is that the risk calculator does not include lipoprotein A, ApoB, coronary calcium scan, or family history of premature ASCVD. So, as an internist or any doctor, they have to take into consideration this separately. So, her calculated risk is likely an underestimate because lipoprotein A of 200 nanomole per liter is major risk enhancing factor, and ApoB is also elevated. She has hypertension and elevated LDLC. And this is exactly the type of patient for whom ACC and AHA guidelines recommend considering a CSE scan to refine risk and guide treatment intensity. So I have not been able to the intermediate medical, what do you call the before HMO, the contracted group, and I talked to them about approving CSE, and they passed on the buck to the insurance company. So they have given me number to call. So next week, I'm going to call HMO and talk to them about approving CAC for this patient. So I wanted to discuss this real case, and it's very fascinating. But the more we know about this kind of cases, the real case, the better is to understand where we are going. And unfortunately, lots of people um, watch YouTube videos and other videos on social media, and they have very adversarial opinion about a statin, and they don't want to even try. Um, so that's the case with this lady. I hope this case highlights important points and helps you in one of your cases in your clinic, or maybe you are one of such patient, and you can talk to your doctor about when you should consider coronary artery calcium scan, because this can definitely help you stratify the risk for heart attack and stroke. And then maybe in that situation, you are able to take better action, because the risk definitely would, um, higher risk perhaps will be more motivated. But you got to understand that it's only 10-year risk. So if you're young and you want to live for more than 10 years, um, then of course you have to think beyond 10 years. If somebody in 70s and 80s, it's a different story. But if you're 50, 60, or 40 years old, your whole life is ahead of you, and you have to go beyond 10-year calculation. And we don't have any tools which predicts, next 50 years, and it's not going to happen. Maybe with the AI, there will be some better model for risk calculation. So thank you for watching. I'm Dr. PK Pankaj Karan, practicing in California for last 30 years. I'm board certified internist. Thank you.